We'll move on to Dr. Jacob Koshy. Sir is a professor of ophthalmology at the Believers Church Hospital. I've known him for many years, and sir has always been a brilliant surgeon and a man of few words, actually. But when you see his surgery, you know the level of skill. He's equally proficient in all of us do phaco and MSICS. But here, today we'll be talking only about MSICS. So I'll be talking to us about PCR and secondary IOLs. Over to you, sir.
Thank you so much, Dr. Ashish. I'm honored to be here as part of your IC. I know that I'm in the company of very fine surgeons, both on the dais and on the stage and off the stage, and even finer people. And I'm going to share some cases that I found difficult and what I did. I'm sure there'll be better ways that maybe some of you have done, and we can look at that. Okay, so we start here with dense posterior polar cataract, and we're wondering what to do, whether everything will go well. Many of us who face posterior polars, we somehow think that, many a time there is no posterior polar adhesion to the capsule and we get away with it, so we get a little complacent. Now, I want you to watch very carefully here. The rhexis was done. Please watch very carefully as I do a hydro procedure here. As I'm doing the hydro dissection, just keep watching, I'm trying to do it very gently. I was not planning to have the fluid pass through behind. I wanted to do a multi-quadrant hydro dissection, and there you see right there a pupillary snap. That's a first sign that you have trouble. Stop immediately. I just put visco. I was scared that the lens might go down. I wanted to get the lens out of the eye and then reassess to see what's happening. So pupillary snap, as you can see there, that's a warning sign. Please take it very seriously. And here, when you're getting the lens out of the eye, don't turn the irrigating fluid on. So here I'm reassessing, and I find that there is a tear in the posterior capsule. Otherwise, so you do a dry aspiration, keep injecting viscoelastic and do a dry aspiration. Don't turn on the irrigation aspiration port. And then you reassess here. I'm just using a Y pusher to see how clean it is and what to do. PMMA lens will come in handy. Whenever you have some cortical matter left, just clean it up. If you have vitreous in the anterior chamber, you want to remove the vitreous with an anterior vitrectomy. Dry aspiration very gently all around. Keep reassessing to see what you've done. You can see the tear there in the posterior capsule. Inject viscoelastic under the iris and not into the bag when you're going to place in the lens. And then here you're putting the lens very carefully over the anterior capsule in the sulcus. And be especially careful when you're dialing the second haptic in, and if you get it into position, and then all's well that ends well. But sometimes we have your heart in your mouth. Don't be scared to do an anterior vitrectomy. Please do it whenever you need to. Here's another case. You can see the subluxated lens inferiorly. Now, for all of you who do complicated cataract surgery, you'll know that the rhexis is one of the toughest steps in this. At least I find it very tough. I very, very rarely use the capsular rhexis forceps. I'm much more comfortable using a cystitome, but here, if you try to do it with the cystitome, you will extend the zonular dialysis. So rhexis forceps is much safer. Go all around and try and get the rhexis done. Be willing to regrasp the rhexis whenever required, and keep putting viscoelastic. And once that is done, now the thing is, should you do hydrodissection, should you not? I always do a very gentle hydrodissection, trying to get one end of the capsule out. Once that is done, one end of the nucleus out. Once that is done, I usually use the two-hand technique, and I get the nucleus into the anterior chamber. Irrigating vectors is my preferred method here. Like I said, you will not turn on the irrigation. You just use a direct vectors. Here, fortunately, we did not have much. We did not have any vitreous there. It was just a small zonular dialysis. You clean up. Now when you're putting in a PMMA lens, make sure you dial the haptic into the area of the dialysis so that it stretches the zonular dialysis. There is no vitreous here, and with that you should be able to finish the surgery. Don't feel hesitant to use capsular tension rings in subluxated lenses. Make sure you have an intact capsular excess. Do not put a capsular tension ring in if you do not have an intact rhexis. Do not put a capsular tension ring in if you have vitreous. The trickiest part is this last part, and if you're not careful, the edge goes back under the iris and not into the bag. Make sure it goes into the bag. Once it is there, then you can proceed with the surgery. Here's another case. You have a subluxated lens here. The difference is there is already some pre-existing vitreous there, and you're wondering what to do. So I made a small rhexis, and now I know that I don't want to manipulate too much. I need to extend my rhexis a little more because I need more space to get the nucleus out. I cannot get the nucleus out with a small rhexis, so I make a second rhexis. I'm trying to use my technique of using two instruments and trying to get the nucleus into the anterior chamber there. Now, once the nucleus is out, you do your dry IA again. Keep reassessing to see how much of capsule you have. Here I've done a vitrectomy, which I've edited here for want of time. And I find that my capsular support is adequate, and I decide to put in a PMMA lens in the bag. Sometimes once you put the lens in, not in the bag, in the sulcus, once you put the lens in, it might move to one side. That's probably because one end of the haptic is in the bag and one is outside the bag. You need to redial it and make sure that you have both the edges outside, and with that you should be fine. Always put in a drop of pilocarpine to just get the pupil down. I always put an air bubble at the end of the surgery to keep everything in place. Slightly more trickier here when you have a much more subluxated lens, and here you can see that I couldn't really salvage it. I needed to bring the whole thing out. Now these would be the situations when you would like to do an iris claw lens. You do an anterior vitrectomy, and then an iris claw lens, retrofixated iris claw lens is being placed there. That's the first enclavation that is there. Again, an iris claw lens, in my opinion, is easier to do than a scleral fixated lens. If any of you are transitioning to doing these more difficult surgeries, try and learn how to do iris claw lenses first. Make sure that the pupil is intact. Here, there's an anterior chamber IOL which is leading to some early endothelial decompensation. You can see pseudo-exfoliation there, and I decided to explant that lens and then put in an iris claw. Like I said, make sure that the iris is intact, make sure that the pupil is round. Do not choose patients who have iris atrophy. Do not do these difficult ones, pseudo-exfoliation ones. Here's another one where a PCIOL was found in the anterior chamber on the first post-op day, one of the residents doing the surgery, and then we had to take it up on the first post-op day, explant that lens, and do a vitrectomy and put an iris claw lens, and that would be how I would manage some of these cases. Now this is a lens that is almost hanging down, and I just wanted to say what I did. It is so difficult to do these superior subluxations. I had to actually put a vectis from the 6 o'clock position to just hold that and then open up the wound on top. I'm just trying to get that into the anterior chamber, heart in your mouth surgery when you're doing things you're not comfortable with, and I'm trying to exchange it now to get it out of the main wound. And you get the whole lens out, then breathe a sigh of relief, smile at your sister, do an anterior vitrectomy, and then you can continue with an iris claw lens or an SFIOL, whatever you're comfortable with. And here again, a trauma case already. Lensectomy was done with a vitrectomy. You can see that you can barely see any iris. The patient was complaining of glare, couldn't see anything. Now, obviously, here you want to put in a scleral fixated lens, and so the pockets are being made there. I usually do a 4-point fixation. I'm just speeding it up. You use 9-O-proline now and not 10-O-proline, double-armed long needle sutures, and doing the railroading technique, you pass the proline through and bring it out. This is a 4-point fixation technique that I'm showing here. And so you repeat that twice, and then the suture is exteriorized, and now this is being tied to the scleral fixated lens. The only difference here is that you have these slight holes there where you can tie the suture, otherwise it looks exactly like the normal PMMA lens that we put in after SICS surgery. Once that is done, now we carefully insert the lens back into the eye, and we pull on the sutures from the side to get the lens into position. And once that is done, the sutures are tied, and now so I'm happy now the lens is well centered, but the second problem of the patient was glare. And now at this stage I'm trying to see, now that I've put the lens and I'm comfortable with that, I want to see if I can prevent glare. So I wanted to do a pupilloplasty along with that and see if I can bring down the pupil at least inferiorly, because superiorly the lid will give a little bit of cover. So here I'm now stretching the iris over there and just trying to see if I can release any synechiae and see what is left of the tissue there. And finally I decide to do a pupilloplasty. I'm not going into the details here. This is a CSO pupilloplasty, again a technique that you can easily study on the internet. All the data is available, and you can try it for any of your iris repairs. So you do a CSO pupilloplasty there, and then once you tie that, you can see that I've at least formed some amount of, got the iris and some kind of support inferiorly, and this patient did quite well. Thank you so much for your patient hearing.